If some sexually transmitted diseases go untreated, a very serious disease called pelvic inflammatory disease can result. Pelvic inflammatory disease, also known as PID, is most commonly caused by an ascending infection from either undiagnosed or subacute chlamydia infection or from an acute gonorrhea infection. Chlamydia and gonorrhea most commonly cause cervicitis or infection of the cervix. Now, if they go untreated, the bacteria can ascend and cause a progressive disease. The bacteria in this case can ascend similar to E. coli in a urinary tract infection, and they can infect the upper female genital tract, including the fallopian tube, as well as the endometrium, and even it can cause a tubo-ovarian abscess. If it infects the endometrium, it causes an endometritis. If it infects the fallopian tube, it causes a salpingitis or a hydrosalpinx. In a worst case scenario, it can lead to a tubo-ovarian abscess. Pelvic inflammatory disease is characterized by cervical motion tenderness. Also, we typically will see a purulent cervical discharge, but sometimes we won't even see that. If things could get even worse, infection of the fallopian tube can lead to scarring and fibrosis, which leads to an increased likelihood of an ectopic pregnancy. It can actually lead to infertility, chronic pelvic pain, and adhesion. This is why it is extremely important to screen patients for chlamydia and gonorrhea once a year and to make sure they are properly treated. In addition to infertility and other problems, if untreated, PID can lead to what is called Fitzhugh-Curtis syndrome. In this syndrome, we can see an infection of the liver capsule that manifests as classic violin string adhesions of the parietal peritoneum to the liver. Now time for a flash quiz. Can you tell me which virus causes a tender rash on the hands, feet, and mouth of children? And to which family of viruses does it belong to? The Coxsackie virus type A is the virus that causes hand, foot, and mouth disease. This virus belongs to the picornavirus family. As we have talked about in the past, a nosocomial infection is a fancy term for an infection acquired in the hospital. It can also be acquired in other healthcare settings, such as a nursing home. So although we think about these places as places of healing, hospitals and nursing homes can also be a home where patients can acquire very serious disease. Think about it. A hospital is a place that is concentrated with some very sick people staying in close quarters. This gives an opportunity for very nasty bugs to live, spread, and thrive. This actually is a very serious problem, and the CDC, or the Center for Disease Control, estimates that close to 100,000 people die each year from a nosocomial infection. Now, do you know what the two most common nosocomial infections are? This is the E. coli urinary tract infection and a Staph aureus wound infection. So the best way to organize these nosocomial infections is to associate them with a particular risk factor that is commonly seen in a hospital or healthcare environment. These include patients with altered mental status or old age, recent antibiotic use, immobility or being in bed rest for long periods of time, intravascular or urinary catheter placement, being on mechanical ventilation, or being on renal dialysis, having water aerosols such as a nebulizer. All of these scenarios listed here commonly are seen in hospitals or healthcare environments, making them risk factors for our nosocomial infections. So think about it. Do we see patients with renal dialysis access in the supermarket? No, or at least I hope not. How about endotracheal tubes? No, not usually either. What we might see out in the real world is urinary catheters and possibly intravascular or central line catheters. The point I'm trying to make here is that these situations, for the most part, are unique to the hospital and put patients at risk for the infections that they otherwise wouldn't be at risk for. So now let's go through some of the pathogens and symptoms associated with each of these particular circumstances. I highlighted 3 of the most high-yield nosocomial infections in the next few slides. In these next slides, I want to go over a thought process that will help you understand these infections in a logical way. So first, I want you to consider the circumstances of the patient presented, then think about the way they're at risk and because of those circumstances. And then I want you to think about the disease that they may be predisposed to because of the circumstances, and then also think about the bacteria that may be causing the disease. So starting with the patient with an altered mental status, typically someone who is at older age. Now, what do you think these patients are at risk for in the hospital? These patients are at risk for aspiration. And what is aspiration again? This is the process of inhalation of material into the lungs in a broad sense. Now, what disease are you worried about in a patient who possibly has aspirated? We're worried about the development of a pneumonia. So in pneumonia, we would maybe see a productive cough with purulent sputum or even a new lobar infiltrate on chest x-ray. So now can you remember some pathogens that are responsible or can be seen in an aspiration pneumonia? So remember, aspiration pneumonia typically are caused by polymicrobial infections, usually with anaerobic bacteria from the GI tract or oral cavity. So thinking further, do you remember the first-line treatment for a patient with an anaerobic pneumonia? We would treat the patient with clindamycin. Remember, clindamycin treats anaerobes above the diaphragm, while metronidazole treats anaerobes below the diaphragm. So now, before we move on, in addition to those with altered mental status, can you think of 2 other populations of patients who are at risk for aspiration pneumonia? I can think of 2 alcoholics and patients with seizure disorder are predisposed to having or suffering from aspiration pneumonia. The next patient group I want to consider are those that are in bed rest, immobilized in their bed, say possibly after surgery. So what kind of things are these patients at risk for by being in these circumstances? Patients that are immobilized in bed for long periods of time are predisposed to the development of decubitus ulcers. These patients post-surgery also could have some residual surgical wounds, most likely. Now, this sort of circumstances can predispose these patients to some certain diseases and symptoms we should be thinking about and worried about. And what do you think those could be? Well, these patients could develop infections, that would be kind of characterized by induration, tenderness, and abscess formation. And what pathogens would you be worried about in these types of infections? Well, we'd be worried about Staph aureus. Most importantly and most scarily, we'd be worried about MRSA. And we can also see anaerobes form in wound infections as well. But the most important infection to consider in a wound infection is MRSA. Do you remember the first-line treatment for a patient with MRSA? Be vancomycin. Very good. All right, patients on mechanical ventilation are also at risk for some negative outcomes. What do you think patients on mechanical ventilation are at risk for, given their circumstances? They're at risk for infection. Remember, anytime you have a foreign body, in this case an endotracheal tube, there's a risk for infection. What disease do you think would most commonly result from an endotracheal tube placement? And what are some associated findings or symptoms that you would expect? Well, we're most worried about pneumonia, which would be identified with lobar infiltrates on x-ray, as well as maybe some purulent sputum and maybe even a sweet odor as well. Now thinking about some pathogens, which pathogens are you considering here? Well, I'd be worried about Pseudomonas, Klebsiella, Staph aureus, and Acinetobacter as well. These are possible sources of infection for patients on mechanical ventilation. I want you to remember this thought process as we list out the other nosocomial infections. I want you to think about what patients are at risk for given their circumstances. I want you to think about the disease maybe and some of the symptoms seen in the disease. And then finally, I want you to think about some pathogens that could be seen in particular circumstances. Antibiotic use, IV catheters, needle stick injuries, and urinary catheters are the final nosocomial risk factors we're going to discuss. Do you remember what antibiotic use predisposes patients to forming? Patients that have recent antibiotic use are at risk for bacterial colonization, specifically by C. difficile. In these patients, we'll typically see a watery diarrhea and leukocytosis. Okay, how about patients with IV catheters? What are they at risk for? These patients have a plastic tube directly in their vein, so these patients are at risk for infections with bacteria on the skin, such as Staph epidermidis and Staph aureus. These can form line infections and can dangerously progress to bacteremia. Clinical findings in patients with a line infection would be erythema, tenderness, and induration at the access site. Needle stick injuries are also common in the hospital and can lead to the spread of certain viruses. Hepatitis B and C virus, CMV virus, and HIV are all viruses you want to worry about with needle stick injuries. Finally, urinary catheters put patients at risk for ascending bacterial infections that can cause urinary tract infection, most notably by E. coli, but also can be caused by Klebsiella and Proteus. Patients who have a urinary tract infection will typically demonstrate dysuria and could potentially have leukocytosis or costovertebral angle tenderness, which is significant for pyelonephritis.